Hello, I'm Dr. James Lee Jr. I'm a board-certified orthopedic surgeon. Welcome to my YouTube channel. Today we're going to talk about the knee. The knee is a very interesting joint. It allows us to walk, it bends, it extends, and it actually rotates a little bit. When we evaluate a patient in the office for knee pain, we're looking at a few things. We start with how they're walking. Are they limping? Do they have limited motion? Can they not bend the knee all the way? Can they fully straighten it? Is there swelling? Is there pain? And from there, we'll talk more about their history. What happened? Were they injured somewhere? Did it happen over a long period of time, a short period of time? We'll get their medical history. Are there any special medications? Do they have diabetes? Do they have any underlying health conditions that might affect what goes on with their knee? Some things that come to mind would be rheumatoid arthritis, sickle cell disease, lupus, just to name a few. When we do a physical exam, after looking at how they walk, we inspect the knee joint and we look at a few things. Number one is range of motion. What does that mean? It means what can that patient do when they bend and extend the knee? Do they need help when we flex it for them or extend it for them, or can they do it on their own? In addition, we inspect the joint. Do they have pain along the joint line? Do they have fluid inside the knee? Does their kneecap hurt them? Do they have trouble lifting the leg? Things that come to mind are fractures, injuries to the tendon, patella tendon or quadriceps tendon. Is there a meniscus tear? Is there a ligament injury? And as we further examine them, we start to come up with ideas as to what is wrong. After we've done the full physical examination, we may consider getting x-rays. An example of why we would get an x-ray would be if a patient has arthritis. If we suspect arthritis in the knee after doing a physical exam, we'll get an x-ray of the patient standing up so we can see what their joint looks like with gravity and their body weight, and to examine whether there's asymmetry, are they bow-legged, are they knock-kneed, and then the x-ray can show us how bad that is, and we can measure it. If it's something like a ligament injury, such as an ACL tear, or maybe a patella tendon ligament injury, we consider an MRI. At that point, we look inside the knee joint, we can see the structures, the cartilage, and we can tell whether there's a tear or no tear. From that point, after we've done our diagnostic workup, which includes, again, our history, our physical exam, imaging studies, then we come up with our diagnosis. And once we have our diagnosis, then we can offer treatment. In our practice, we have a community practice, and generally speaking, the knee issues we see range from arthritis, which is probably number one, meaning there's wear and tear in the knee joint. Number two would be meniscus tears, where there's an injury to that special cartilage. We call it the shock absorber in the knee joint. And then we see a various array of other injuries involving ligaments such as the ACL or anterior cruciate ligament, posterior cruciate ligament. There might be a ligament tear on the outside of the knee or the inside part of the knee. And then we'll see fractures as well. That's just a few of the conditions we see. At that point, the patient and I and my staff, when we have our discussion, we offer them options for treatment. Number one, maybe nothing, leave it alone. Observation. Say, okay, you might have had a flare of your arthritis. We're just going to watch it, come back and see us, plus or minus medication. Two would be physical therapy. Will that offer helping the muscles build, helping get the swelling out, helping to improve somebody's ability to walk? Number three, consider an injection. Are they a candidate? Maybe they are, maybe not. And then if they have an injection, there's different types. Steroid injection. There's also a biologically friendly one called platelet-rich plasma, where we draw blood and we draw out the healing factors and we inject that. And there's other types of injections as well. One is called a lubricant or hyaluronic acid injection. Think about oil for the engine in your car. We inject that into the arthritic knee to try and get the lubrication and the friction in the knee to go away, or at least lessen. And then from there, potentially surgery. All right? Are they in a category where the knee might need a knee replacement if it's bone on bone? Are they more maybe recreational athlete or a professional athlete where they have a small injury to the cartilage or ligament? Do we then do an arthroscopic procedure that's minimally invasive? We go in through 2 small incisions and we do our correction that way. Or is there something broken? Maybe there's a fracture of the knee, either the femur bone, end of the femur bone, top of the tibia. Do we have to go in and fix that? And then, as I mentioned before, patella tendon or patella ligament, quadriceps tendon, those can also be injured and then on occasion have to be repaired. These are some of the things we see. The knee is probably the most common ailment on a weekly basis. And if you have any further questions or want to know more, please contact us. Thank you very much.